that's not my bio.
Off my
yeah, Jeff Lee. Sorry.
Sorry, not sorry. No, I'm just kidding. So here I'm going to switch to gallery view so I can see everybody at the same time. So raised in poverty and a history of systemic brokenness, Jeff Lee carried on his family traditions with years of drug addiction, gangs, crime, and violence. Having spent many years in and out of jails and prisons, Jeff's last prison sentence was at the United States Penitentiary at Leavenworth, where he finally began to put the pieces of his life together. After being released from incarceration into an unfamiliar world, Jeff enrolled in the Pathways to Success program, where he was able to gain the tools necessary to live a life free of crime. Jeff went on to become an ordained minister, homeless outreach director, and social activist for those returning from incarceration. Jeff came back to Connections to Success to become the program director of the Kansas City location and travels to jails and prisons across the country in his quest for justice reform, as well as giving lectures on college campuses. He serves on many advisory boards and is a member of the UMKC Institutional Review Board on matters involving incarceration. He's married to Rebecca, a doctor of psychology at the VA, who's done extensive research on the mental health of justice involved individuals. They have 3 children that they are raising in Kansas City's West Plaza neighborhood. Jeff is also an avid marathon runner, disc golfer, minister, and is passionate about serving the Kansas City community. And then we have Car Wu. In 2008, Car Wu founded Artists Helping the Homeless to fund a Sunday night meal program through art events and sales. As AHH learned the stories and needs of the homeless, they found that they could link them with the resources to help them. For Wu, who majored in psychology, this program brought together his business, art, and psychology training. In 2010, through funding from the St. Luke's Foundation, AHH was able to purchase their Be the Change van to address the critical needs of the homeless population. This funding also allowed Carr to close his store and be able to focus his full attention on developing the program. Today, AHH has served well over 65,000 meals, and the Be the Change program operates 100 hours per week with a staff of 5 and volunteers crisscrossing the community. So welcome. Thank you guys for being here.
Thank you.
I just want to give each of you a couple of minutes to talk a little bit more about your organizations, and I'll go ahead and start with Kirsten again.
So Pathway to Hope has been around for about 20 years. We started as, I would call it a peer organization, from the sense that our founders had a child with mental illness, serious mental illness, and they found it really difficult to find resources for their child. And as part of that process, they learned how to advocate for themselves, and then they used that energy of what they learned to turn around and give it back to the community. So we started with support groups, and they used an education course, and about 10 or 12 years into it, when the diagnostic manual was changing and that course wasn't going to change, they wrote their own course that we use now. It's called E3, and we're in the process of updating it again because science is changing so fast that now we have to update about every year. And then in 2007, we opened a house for individuals who have lived experience with mental illness. It's a peer support house. We don't have anybody living there on site with them. We do have volunteers that support them on a daily basis. They're there checking in, but there's nobody living on site, so they have to be able to live on their own. And then in 2019, we started a program called Clubhouse, which Clubhouse is a model that's used in more than 300 locations internationally. So it's not just in the US, but also internationally. It's a day program for adults living with serious mental illness, and it provides community and resources and support, and the focus is really on wellness and much past the application. We really don't talk about mental illness. There's an obvious, we all know that what we're there for, but we're not there for mental illness. We're there for wellness. And it's very satisfying to have that program, because you know that you're contributing so positively to people's lives. I just was at the Clubhouse this morning and asked for an update for numbers of members. So to be a member, you have to be an adult living with mental illness. Those are the 2 identifying factors. Of course, you need to be motivated to participate, but that's about it. So during 2020, when everybody was staying in and we're all kind of withdrawing, we attracted 90 people to join the Clubhouse. And they have an average daily attendance right now of about 11. Some days it's a little bit more, some days a little bit less, but that's a good average daily attendance. They, of course, are keeping all the precautions, masks and social distancing, and wiping down all of those surfaces. But it really has been a blessing for people who would have otherwise spiraled to have a place where they could go. And then finally, we're looking at the future and some really neat things that I think are on the horizon as we continue to address the need, primarily in Johnson County, but we don't say you can't use our services if you're from someplace else. It's that we're in Olathe and Shawnee, and so primarily we're serving Johnson County.
And full disclosure, I am also on the board of Pathway to Hope as development chair. And we do have several other league members within the organization that are also on the Dancing with the Stars committee for Pathway to Hope. So thank you, Kirsten, for being here.
Thanks for having me.
Yep. Jeff, over to you.
Can't just drop Dancing with the Stars on us and then just kind of move on quickly. Hold on, wait a minute. Dancing with the Stars?
So Dancing with the Stars, we kind of started to roll it out a couple of years ago. And then of course, COVID came along and forced cancellation of the event last year. And then of course, again, this year, because obviously our dancers need, some time to rehearse. So hopefully COVID cooperates with us and we can actually really get it off the ground next year.
That's really great. When I used to be the program director over at Hope Faith, they call it, it used to be when I was there, ministries, but Hope Faith Ministries, and they did something similar, but they used local celebrities. Is that what you're?
That's exactly what
we're doing? That's so good. That's so Car, you got your role next time. Local celebrity, they can get you out there on the dance floor. No, seriously. No, you're not doing that. Okay, so yeah, again, my name's Jeff. It's a pleasure to be with you all. Thank you so much for having me, Ash. Thank you to all of you. I am the program director of Connections to Success. We are a agency that serves in Kansas, in multiple locations throughout Kansas, the Kansas City, Missouri area. We serve in the Columbia area. We have a few offices out there. And then we have offices in St. Louis, to include Illinois, East St. Louis. But we like to say we cultivate a hope-filled family atmosphere where people feel welcomed, supported, and empowered to discover their strengths, build self-confidence, learn new skills, and practice accountability for creating the future that they desire. And we do that by equipping families impacted by generational poverty, either incarceration or unemployment or underemployment. We give them the skills and resources to reach their goals and achieve that economic independence. And we do that through our evidence-based Pathways to Success model that combines the best of workforce development and cognitive behavioral intervention strategies. And then we do that. When we do that, we create this unique, experiential, and highly effective program that promotes success in all aspects of life, because we're not just about getting jobs, we're about building careers. And we do this in a multitude of ways through either our workforce readiness training and partnering with local community colleges or skills trades schools that we can provide real tangible certifications that individuals can take into the workforce. We do healthy relationship training where we do manhood, womanhood, and then ultimately healthy relationships. And we do that in a kind of a generational model, holistic model, where we're providing the whole family involved in that. We, of course, have job development teams, and we implement strategies to connect employers with our participants, and we have life coaches that are involved. We don't like to use the term case managers. We just simply call them coaches that coach individuals to stick to their goals, to stay on target for their goals, and ultimately we do that through a variety of ways. But our bread and butter is our personal and professional development training. It's the cognitive behavioral development training that is a community-based model where we bring individuals into a classroom, and we start from that place of getting a person to believe in themselves first, to believe in their gifts and their unique talents and skills, and move them into a position. Now we're ready to go look for the job of your dreams by matching you with your opportunity, then your skill, and then your passion. And we try to meet those together. And we primarily help those returning from incarceration, those that are inside of the institution. Obviously with COVID, we can't get back in there, but we have a great relationship with the Missouri Department of Corrections and the Kansas Department of Corrections to help individuals affected by the justice system.
Thank you, Jeff.
Yeah.
And Carr, would you like to tell us a little bit more about Artists Helping the Homeless?
Yes, we have grown a little bit. So I started this program like when I was having a gallery on the plaza. I noticed there's homeless people on the plaza, which surprised me. I didn't understand why there's homeless people on the richest shopping area. So I took 20 sandwiches down to the park, and then that's how it started. Very, very innocent. And so then we become full-time. Like this is my 13 years full-time now. It's kind of blowing my eyes. It's kind of crazy. We actually now have 7 mans, and we have 17 helps now. We've grown a little bit. In the beginning, what I did is when I was transporting these people from hospital to different places, I get the opportunity to listen to them and find out what their needs are. Over time, we try to fill out the gap surface, the surface that's not being presented, because we talk about continual care all the time, but all the service are silo business. So emergency room will take care of your presenting symptoms. Detox would address your detox. Inpatient is inpatient, but it's never a true continual care. So we created different services to fill those gaps to create a true continual care. So everything we do are our need, is our desperations, truthfully, because we try to help people to get somewhere, but there's no service. So we found and say, well, we'll just do it ourselves in a sense. And so over the years, we have created what I call a respite house. The respite house is basically to house people to have a chance to slow down, to reflect, to learn, and they don't have to worry about how to pay rent. They don't have to worry about how to pay food. The only thing we ask them is do their reflection, and then we will work with them to kind of get to the next level. There we provide all wraparound service. We provide them food, housing, transportation to work, to school, medical, dental care, counseling services, and things like that, so that they become a whole person. Since I'm Asian, education is really important. So we encourage them to go to school. So whether they're going to like a vocational training, and lately we've been partnering with Skill KC to get a little bit higher end training, or go to college or get a GED. Most of the young men I work with, when they go to college, they all get 3.5 to 4.0 because I'm Asian parent, so I can demand more. And so over time, we have become this community's difficult discharge planner. What I mean by that is every hospital, every site unit, every detox, every inpatient, jail, all call us to help for discharge planning. And so we usually I will personally go to all these facilities to do assessment to find out what their needs are, and we will try our best to guide them through the system. Either we can house them ourselves or find the right appropriate places that's best for them, because our goal is individual tailored, because nobody can be one size fit all. So we try to find the right program for them. The goal for our program is always to start with the individual, find out what their wants and needs are, what their aspirations are, then work with them from there to move on. And we never judge what the past are. We only ask where you want to be at. So, and then that philosophy seems to work. So a couple of years ago, Douglas County got wind of what we're doing. So they invited us to duplicate our program in Douglas County. So we have started that program 2 years ago. So usually I work with 2,000 people a year. So last year with the COVID-19, it was really, really challenging to work with people. A lot of service provider has to cut back because of the COVID. So to try to help flatten the curve in the hospital bed. So our desperation last May, we created what I call the shelter in place program. So basically it's a hotel stay program that we help the hospital discharge patient out of the hospital. So that program itself, we house 200 people in 11 months. We just closed it at the end of this month. In fact, because now the COVID kind of calmed down a little bit, so we didn't feel like we need that, and the winter is over. So in that sense, in that program alone last year, our little organization that housed over 200 people in that program alone. We normally house around 200 people every year. But we're constantly learning to adapt to what is needed. I think as a small nonprofit, we have the capability to kind of adapt to what's currently needed. And I think that's really important because we have to work with what is needed and what is not what we want them to do. So we are very thankful we could do that. And so last year alone, we have housed close to 400 people in our little program through our regular programming as well as the shelter in place program. But I'm very thankful that I was blessed to be able to do that. I always joke with myself, who get to do this? So that's about it.
Thanks, Car. And being Asian myself, I totally get the whole Asian parent thing.
Yeah. I know, okay. So they actually,
you can't have anything less than that. That's not acceptable.
No, they get B's, they worry because they would call me and say, I got B. I say, well, where's the A?
Yep, I used to get scared too if I came back with a B. So I want to go ahead and move on. So I kind of just to clear some things up and make sure that everybody's on the same page, I want to ask you, what is mental health and what are a few issues that maybe we often don't think of as mental health issues?
Well, I think that we all have brains, and because we all have brains and brains are sort of driving us, whether or not our brains are functioning in a healthy way is what mental health is. There's a neuroscientist by the name of Dan Siegel, and he says that the mind uses the brain to develop a sense of self. And so if the brain is broken in some way, chemically it has a problem, or maybe developmentally it has a problem, you're going to develop what's called mental illness. And we call it mental illness because it's diagnosed through a diagnostic manual. Typically, mental illness is affected by changes in emotions or thinking or behavior or some combination of those three. And they're typically diagnosed based off of behavior, like what can be observed. There's not really a nice lab test or a scan or an x-ray that you can diagnose a mental illness from. And we typically evaluate how somebody is functioning socially or with their family or with their loved ones. So it's kind of a big, broad description of what mental illness is. The statistics say that 1 in 5 folks are going to have a mental illness at any point in any given year. So it's about 19% of the US adults are going to be affected or impacted by mental illness. About 1 in 24 are going to be impacted with serious mental illness, and that's going to be diagnosed such as schizophrenia, bipolar disorder, borderline personality disorder, major depressive disorder, extreme generalized anxiety disorder, those types of things. And most of those are treatable, though treatment is kind of confusing. We've talked about continuum of care already. We've talked about the complexity of the system. And so that it can be a little challenging to really get a diagnosis and then get into the right treatment. And then of all of the mental illnesses, one of them I think that surprises people when I'm talking to them is that substance use disorder is considered a mental illness, and about 1 in 12 people are living with that. One of the other things I think is really interesting, and I think this is really important for society today to understand, is that neuroscience is beginning to help us understand that mental health drives physical health. There's lots of research out there that says that childhood trauma and life stresses, which impact the brain, drive all kinds of things that happen in the body. So asthma and cancer and MS and all of those things, there is actual science that says there are links to childhood stress and trauma, and how our physical health is experienced in adulthood. And I think we want to understand that now. And I don't think that we do understand that very well. I think the way that we would treat mental health and mental illness would be different if we understood that mental health drives the bus, not necessarily physical health. Like mental health keeps us healthy in our whole bodies. So that's what I have to say.
Anybody want to pitch in on that? Okay.
Yeah, no, she hit the nail on the head, right?
Yep.
I would say anecdotally, though, like she's right on point, is we were dealing with an individual that was hearing voices in their head, and the doctors kept prescribing medications for schizophrenia, and she seemed to be getting worse and worse, but come to find out she had a thyroid issue, and we took her to the World Outreach Foundation there at Hope Faith, and Jerry and his team were just gracious enough to walk through and try to figure that out, and found a direct link between her body and her brain, and how the mind is affected by the body and the body affected by the mind. So it's all interconnected, and figuring that out, I think, if I may be so bold, I don't think we're far along enough in understanding the brain, and treating psychology and mental health in the same breath as we speak of our physical needs. Is we're so quick to talk physical needs, and I think we're lagging a little bit behind in understanding the mind. We
forget that the brain is an organ.
Mm-hmm.
I often say when I'm asked to speak that we know more about deep space and the deep ocean than we know about our brains. And that's because ethically, you can't go in and, poke around on somebody's brain like you can the ocean or space. But the truth is our science is really advanced in lots of ways outside of the body. But inside the body, we haven't done a lot of advancement. And there is a reality in psychology to hold on to the ways of diagnosing that we've done for years and years, well, since Freud, right? To do a clinical interview and ask people how they're feeling and collect the symptoms and then diagnose them from that. But I think we're going to see a push in the next 10 years that they're going to push the medical field to think of the brain as an organ and look for ways to diagnose better.
Great. So how would having mental health issues affect a person's ability to function at home or school or in the workplace? And what outcomes can be expected if these problems are left untreated?
I'll take that one because I think you guys are going to get some that you're way better with later. So I think if we think about mental illnesses being things that affect our emotions and our behavior and those kinds of things, first of all, mental illness affects all of our relationships. I don't know anybody that's living with any type of strain, whether it be anxiety or depression or all the way up to very serious schizophrenia, that it doesn't strain the relationships. I often talk to the folks that I'm with every day and say, mental illness as an experience is withdrawing. It's isolating, and it makes you feel like you're different, and it pulls you away from the sense of what everybody else is experiencing is normal. And so as a person who would experience mental illness, you're going to pull away, and it requires the people around you to lean in harder, and sometimes come against a lot of resistance as you lean in that attempt to connect with and love and care for the person that has mental illness. I think scientifically, all of us that work in this field could say that if it's untreated, it just gets worse. It just gets more complicated. And not only that, but we just heard in the previous question that the body has more complexities. So one of the statistics says that people living with mental illness die 15 to 25 years sooner than people without mental illness. And part of that's because they don't have access to care and treatment and things like that. But they tend to look at other ways of coping, like maybe drug use or cigarettes or things, alcohol, that's going to pull on your physical health anyway. So, and in worst case scenarios, suicide is the outcome. One study says that up to 90% of the people who die by suicide had an underlying mental illness. And that feels like a controversial statistic because I'm not sure how they could know that. But even if it's not 90%, even if it's half, when knowing that mental illness is treatable and that we can impact their care, it's sad to think that somebody would withdraw to the place that they would die by suicide.
Okay. So in case you didn't know, I am currently the Community Conversations and Advocacy Chair for the League, as well as the incoming Director of Training. And because this is a community conversation, I want to ask all of you actually, why should mental health be considered a community issue?
I want to kind of address that a little bit. Okay, so I'm going to use schizophrenia as one of the things that we deal with. Okay, a lot of time, generally speaking, a lot of people get schizophrenia in the mid-20s to late 20s. The way I look at it is, okay, if I have a son or a daughter, they gone through high school doing great, then they go to college, they're doing great, they find the love of their life and they're doing great, and they have a children, they're fine. Suddenly, the mid to late 20s, suddenly this hit. So the family does not know how to handle it. And in the beginning, they don't know what happened. They just, well, the person is on drug or the person is doing something. And so it affects the whole community, the whole family. So the dynamic, because if they are not educated or don't have the patience or understanding, then they might separate from their spouse or they cannot handle their challenges. So now this poor soul have gone through all these things and suddenly they will lose everything. But it affects all the family dynamic, his work experience or her work experience, or have them accept that they have a mental health issues. I actually worked with one kid that was going through the same thing years ago, a few years back. It took me 4 months to convince him to go see a psych doctor because he does not believe he has the challenge. And he was acting up on every aspect. But it literally took us 4 months for him to settle down, to agree to go to see a psych doctor. And then the other challenge is a community problem is because, like, who is paying for it? And so he can't afford it, has no insurance. And then we have to write it off because it's like somehow, and if they don't write it off, they will carry a lower debt. And so that's also a challenge. Or if the hospital or the site unit is willing to write it off and somebody still had to pay for it. And people say, well, the community pay for it, but somehow we have to pay for it somehow. Things that just doesn't happen. So I think overall it affects every single person. The way I look at it is like, say, if we don't have insurance, so we say, okay, we just go to the emergency room. I'm not going to pay for it. Okay. So what difference does it make for me? But yes, but somehow this is why our insurance is high. That's why our medical bills are high. And so that does affect our community, like it or not. And then of course, the other way is it affects the community. That person might have gone to college. They have a brilliant life. They could be contributing to something in the community, but suddenly we lost that mind. So now we don't have that opportunity to let that person grow. So this is all very, very like intertwined together. So it's not like he has a mental health, that's his problem. No, we are all in this boat together.
I like your point a lot, Car. And I downloaded today from the Health Forward Foundation, buried deep in their recesses. These are from 2015. Are the different statistics for county and city. And I love these because the Health Forward did a big old study, and the one for Johnson County says who pays for untreated mental illness. Individuals in unrealized earnings, they said $99.1 million is lost because the individuals aren't working. 82 million is the private sector, including employers, which means that it's loss of production, paid time off, those kinds of things. The federal government is 21 million and the state and local governments are 21 million. So the truth is, we in the private sector and those individuals are really paying the cost of not recognizing mental illness as a need. And the sad thing is, and I love that you said the family, because truly the family is the most impacted. They over and over again, children are experiencing the trauma, and wives and husbands are at odds, and parents, I talk a lot with parents. Parents are grieving over and over again because they can't get their children the help that they need. And so it's heartbreaking for families and brothers and sisters and all of that. So good. All your points were awesome. Thank you.
I actually, Kirsten, I actually had that exact document in front of me too. So great minds, obviously. So,
you've learned well, Ash.
I know. You've been my mentor in this field. So Jeff, I want you to answer this. I'd like for you to answer the same question.
Well, I think Carr hit the nail on the head with the ostracizing of those that are affected. One of the things that we have as a result of our, I guess, lack of understanding mental illness is our stigmatizing mental illness. Is we look at those who might have a diagnosis as a pariah or somebody that we don't want a part of our community. Is the example that Carr used was of the husband. Eventually that person, because we don't understand how to get treatment, we don't understand how that person could create healthy habits in their life, maybe to change their diet, to see the right doctors, maybe even medication, is we will instead push them outside of our community. And I think so often that takes place in the full gamut of our socioeconomic situation in America. Is we have so many that are suffering from the small to the big issues, and instead of addressing those and being willing to step in and step alongside, we instead cast them out and push them to the fringes of society, thus creating a cycle of crime and poverty and a reliance on government funded care, and a reliance on these funding streams that actually cost us, the taxpayer, more money in the long run. Thus, it's just this huge cycle of interconnected issues that if we but have an understanding and a willingness to understand, we can address these issues together rather than kind of separating them apart. Because the statistics, as Kirsten said, is 1 in 5 adults. I know 5 people, so I'm probably the one. But I know that in as you get your circle larger, that somebody in that circle is affected, and somebody in there needs to be heard, needs to be cared for, and needs to be respected through that process. And we got to have thick skin through it all, or we're just going to continue to cast them away.
I agree. I'm also one of those one also. In fact, that's actually what took me to Pathway to Hope. It actually started off in the junior league, and I was interviewing a league member for an article for our magazine, and that's actually how I found out about Pathway to Hope, because I talked to her about my own mental illness, and she told me about Pathway to Hope. And I do suffer from major depression at times. Obviously, it kind of comes and goes. And I also have an anxiety disorder. And, of course, I've also been touched by mental illness in the fact that I did lose my fiance about 20 years ago this month. So to suicide. He was bipolar. So I appreciate you bringing that up. Now, the next question that I have, and I'm sorry because my screen timed out. I know that Kirsten and I have had this conversation before, but I've heard a lot of times that mental illness is a luxury that only the wealthy can afford. And can you explain the correlation between wealth or the lack thereof and mental illness, which I think we kind of already touched on a little bit.
Jeff alluded to it, but I went and downloaded the fee schedule for Johnson County Mental Health so we could talk about how much it costs to treat someone. I know, real life. A 1 hour session of individual therapy is $75 at Johnson County Mental Health. So we're talking about the government entity, and they're likely billing Medicaid for that. They don't treat people that have insurance. And then they have a sliding scale fee for people who don't have Medicaid or can't pay, and it's based on poverty. So I don't know about you all, but I don't have $75 to pay for 1 hour of therapy. And I'm kind of middle-ish, upper middle class. You know, it's just not my, primary concern most of the time. So the people, and I talk about this with my colleagues all the time, a person in private practice is going to charge somewhere between $90 and $140 for an hour of therapy. That is, to me, crazy. It's crazy that that's what you're gonna pay for. So the wealthy will often pay privately for that, or the people who don't have any insurance at all, or are dependent on the government for their services, will get those services through a system like Johnson County Mental Health. There really is not a big middle, and I have a private practice that I see clients 2 days a week, and I network with other individuals that also do private practice, because I don't want to deal with insurance companies, because I can't tell you how complicated that is. I do self-pay, and I try to keep my rates somewhere around what a copay would be. And some of my other colleagues try to do the same thing. I do a sliding scale also. I will see somebody for as little as $20. That's kind of unheard of. And several of my colleagues do the same thing in order to try to meet that middle ground for people who either don't have insurance, can't pay for that $140 for an hour. It's a really challenging thing, and that's just for therapy. If you think about medication, the example I'd like to give is my daughter, who she works full-time. So she's employed full-time. She has 2 children. She owns her own home in Missouri. She was on Medicaid while she was pregnant, and she knew that she would have so many weeks after she was done being pregnant. She has bipolar disorder with schizoid affective disorder. And so she knew she needed to transition from the care that she was getting while she was pregnant to somebody else. And when she did that, the psychiatrist wrote her prescription wrong. So instead of giving her an extended release tablet, gave her, one that you take and you have to take it multiple times per day. That doesn't work for her. The difference in cost for her, because she was going to not have insurance, was $340 for a month. $340 for a month. And like, you call her and tell her to write the prescription correctly. But she gets frustrated by that's hard for her. She emotionally, she's like, I don't know what to do. And I'm like, call and tell her she wrote the prescription wrong and ask her to write it correctly. And so she pays for her medications out of pocket. She uses good RX and things like that. But there's no middle for her. She can't go to a mental health center and get treatment and get any kind of medication there. And that, I think, she represents a large percentage of the population.
And I want to touch on that a little bit. The economical side makes a huge difference for the low income family, or the homelessness. They can afford that. Okay, they can't even go to the pharmacy to get there. Okay, how are you gonna get there? Okay, and then like, you have a really good point. You're comparing prices. So like, we have all our people that we work with we pay for all their medications. But what we do is we go to Walgreens, we go to get the good RX, we go to Walmart, we go to Costco to find out who has the cheapest medication so we can afford to buy. But you think a homeless person is going to do that? They are not going to do that. So what do? They say, forget it. I'm not taking it. So guess what? The first thing they do is they go back to the hospital. Guess who's paying for that? Us. We are the community, our insurance. So because I don't blame them. Who has the time to run over? I get very frustrated with medications because why can't we have one price for them? Why do we have to work so hard running everywhere? Like I would make my driver go to all different places trying to find the cheapest price. And then say, if you want to go to inpatient or detox, okay, they would not accept you without the medications. Now, how are you going to go there? You have no money. You're just trying to do better. You go to the door and they say, well, do you have your medication? No. Okay, we don't accept you. So those are the things that when you have money, you do take that for granted. You can afford $1,000 premium to go anywhere. But when you are in the low income and homeless, you just don't have the luxuries. So we have to, so again, this is how we affect our economies. So I feel really, really bad for the people that is like try to get better on their own, but yet they can't do that. I just have a client that had to get a blood thinner. The prescription was $3,000. I went everywhere. I couldn't get the price low. So I went back to the hospital, bargained with them, argued with them. Finally, they gave me the medication. But you think that person is going to do that? No, they can't do that. So we have to be like, we have to step up for them and be the advocate to really make sure, hey, I said, well, if not, I'm going to bring him back to you because he's going to die. So we got the medications. So I think that is really important to, as a community, we need to address these things. We can't just take it for granted. The doctor can just write the prescription, assume that we can afford it. There's a little bit more steps to that. Okay, I'm gonna stop my whining.
No, I think you make a great point, Carr, because I think from my level and where I'm at, we receive a lot of our funding from grant-based projects. So I have projects from the Department of Justice, from the Department of Labor, from DSS in Missouri and DCF in Kansas. I have these major government projects that have no line item for mental health in them. I can't spend any of those dollars in that grant funding that is available to me. I can pay for staff and I can pay for computers and phones and I can pay for carpet and I can pay for rent, but I can't pay for one of the major needs that all of our individuals have. And that's when they leave incarceration, they're in need of serious help in terms of dealing with post-incarceration syndrome. And we don't have any money to pay for that. And we have to use, and this is, I did it 3 times last week, is approved from our, what we call petty cash, just cash that kind of comes in off of a donation. We use that. And much like finding medication, I've got to find the cheapest counselor. And I watched my wife go through many of her different internships as she was working on her degree. I watched in these different places, and not to speak ill of anybody or anything. I know that there's so many dynamics that play, but the level of care that are at a place that I only pay $10 because of the sliding fee scale and where it's at and all of that stuff, they're not going to get that same level of care, to answer your question, as somebody who's dropping $150 an hour on a counselor or a therapist. They're just not going to get that same level of care. And I know Lexi put in the chat box is what we see is that, yes, our state institutions are able to address the mental health needs of those that are incarcerated. When they're released, however, they're released. It used to be they were released with 1 week worth of medication. Now they're released with 30 days of medication. But the cycle continues. When they're in the getting released, they're worried about so much: a job, a home, relationships, changing their lives, their probation officer, the court requirements, drug treatment programs. They're worried about any other programs that they got to take. They're worried about a gamut of issues. That 30 days is really fast, and now I'm running out of medication and I don't know what to do. and jumping through those hoops for medication is important for us to address. I think to change something, anything that we can change, whether it's policy level, whether it's hammering down on these pharmaceutical companies, finding real solutions to this, because it's a growing issue. If somebody doesn't have their medications or is able to acquire those, the cycle just continues.
Well, and since we're talking about medication, I just want to say this. It is actually quite dangerous for somebody whose brain is dependent on the medications that they're taking to immediately stop those medications. There are some of them have shorter half-lives, and so it's not quite as dangerous, but some of them don't. And literally, the brain becomes dependent on those things because that's what it's been using, and to not have it, it's dangerous for them and their health. And sometimes it can be dangerous for people around them. I'm not saying that they are the problem. It's the what's happened to their brain because they don't have the chemicals that their brain is needed, and it's a problem.
Yeah, we most recently an individual near Emmanuel Cleaver in Paseo shot his good friend because he had ran out of his medications, and he had gone 2 weeks without them. And unfortunately, due to paranoia and the schizophrenia, shot his friend and killed him. Now he's going the rest of his life in prison. A few years back, we had the same situation where the guy didn't tell anybody. He was released from the state prison with 30 days of medication. He made it to about 90 days from his release before he started the behaviors, and we started noticing it. And by then it was too late. And unfortunately, he murdered 3 people in a car because he thought that they were out to get him, and the delusions that were in his head were strong.
These are some crazy, well, not crazy, but these are some horror stories for sure. And just simply because they can't afford the medication. And we don't have those programs in place. And of course, as you all know, the cost of those prescription drugs in this country are considerably higher than they would be on either side of the border, right? Either on the northern border or the south. So it's definitely a problem. Car, this one's more for you. And you've already kind of talked about it a little bit, but how is homelessness impacted by mental health, and what problems can arise for someone living with an untreated mental illness without a place to call home? And what programs are available to help, and where do you still see some gaps?
Well, there is a lot of gaps. Okay, I deal with mostly dual diagnosis people. Of course, that is like program that is mostly like dealing with homelessness. Like with Restart, they have a rapid rehousing program. Hope Faith has a really good program for day center and things like that. But the challenge a lot of times is it's like when they get out of jail, like Jeff was saying, they come out, they have no place to go, they have no money, so they can't do anything. So I just have a kid that I work with that we try to help because of he got in a car wreck and he doesn't have a place to live, and he has 2 kids, and his wife is not doing they're young, so the wife is not doing the right things. So we try to house him so that he has a stable place because he can't work. His leg was damaged. Unfortunately, in this particular case, he was very, very paranoid. So finally, we realized he's right at the age on the onset of schizophrenia. So because we keep communicating with them, we keep trying to send him to counseling, and we finally realized he's actually have the early stage of onset of schizophrenia because he keep telling us that there's people watching his window and it's not safe and stuff like that. But we're trying to manage it, but then his physical health was not well as well. So we had to take him to the doctor, have a surgery. During the surgery, his paranoia acts so high, and the doctor had to stop the surgery. So that's
Wow.
That we addressed that. I mean, a couple of days later, he finally got his surgery, but it's really, really hard. And so I think, so the continual care is really important. Housing first is really, really important, but housing first without wraparound service, I think success rate is not going to be as good because they are still struggling with the same thing. Just because we give them a place to live, that is wonderful. But we don't provide the wraparound service, the guideline, the counseling, all the other support. The struggle is still real. And I think that's how I look. And a lot of times, like we talk about like your mental health, because then your family does not know how to deal with you, or they get scared. They don't know what is the best way to address those issues. Of course, they stay away from you. They keep their distance. So then it kind of making the problem bigger again. So, and I think so your mental health does contribute to the homelessness. And then at the same time, for them to control their wandering mind, how their mind is, so they might escape to using drugs, because drugs will give them the temporary high, the temporary escape. So now we definitely create this dual diagnosis challenges. So majority of people we work with in house are dual diagnosis people. And so because they might be using the drugs to give them the moment's comfort, but in the long run, it doesn't help either. So I think as a community, we really need to look a little bit more as a whole person instead of just one thing, one incident. So that's how I see it.
I like what you're saying, Carr. I appreciate that. And I think when we look at things like the Veterans Project that they're doing downtown, and some of those things that are focused on a particular segment of people, where they have a home and it is their home and it's not going to be their home. Nobody's going to take it away from them. And then they offer those additional services to them from the place in which they feel secure. Mental Health America has a program called the Heartland Housing Initiative, and they have a number of apartments, and I think they have them in Douglas County and in Jackson County and Wyandotte County. And they're whole buildings, my understanding, and they have the individual comes out of whatever hospitalization, incarceration, they go straight to their apartment, and it's their apartment no matter what. And then they bring all of the services to them. So the case management and all that wraparound care, they bring it to them. And then in the building is peer support. So somebody's always there to support them as they're going through their recovery process. And I feel like it's a really great model for housing for people who have mental illness. The struggle is what you will hear, whether we like to admit it or not. If I were to buy a apartment building anywhere in Johnson County, the first thing I would get when zoning let everybody know that this was going to be housing for mental illness is the big resounding scream of "not in my backyard." And we know that that's true because they did it with the homeless 1020 project in 2 different cities in Johnson County. So we know that's a strong element to not being able to help people the way that we would like to see them helped.
To address it, I think the next is changing some of the guidelines so the 1020 can do something.
Well, yeah, but it took a lawsuit for that to happen. You know, Nexa didn't just wake up and go, "Oh, we feel very much like we want to help these people." I think what they found out is that you can help and it's not going to harm the community. And in fact, it's going to help the community, but it took a federal lawsuit to make that happen. And that makes me sad that we have to sue a city for them to take care of their inhabitants. You know, I'm like going, and Johnson County, you hear a lot, we don't have any homeless people here. I'm like, what? Like, what? I live near the courthouse. I know you see homeless people there. The jail's right across the street. Come on now. You know, so we don't open our eyes to it, and we live in a lot of denial, but I think we can testify that there is not a lack of homelessness in any place in our city. And that it needs to be addressed all across the municipalities of our whatever 26 different municipalities, 2 state lines. You know, there's a lot of places that keep this metro area complicated. I think if each one of us say we want it to change in our city, we want it to be different here, we want to recognize the problem, I think that goes a long ways.
Agreed. So the next question, I think this is probably a little bit more directed towards Jeff, but I know Kirsten has some, just because I talk to Kirsten a lot, obviously. I also know that she probably has some things to say, and Cara, I want you to pitch in too. On January 29th, in Rochester, New York, a 9-year-old girl in the middle of a mental health crisis was handcuffed and pepper sprayed by police after her mom called 911 for assistance. In an ideal situation, what should this response have looked like? And how does this incident point out the flaws in how we respond to a mental health emergency?
I got to guard my words carefully, because I think I think the safe way to say it is you take any individual, okay, and you put them in a position of power and extreme responsibility. I think there should be a certain litmus test for how that person is going to handle that power and that responsibility. We're asking regular Joes and Janes to only have a high school diploma with no sort of training beyond a simple fitness test and maybe a few written exams in a 1 or 2 week academy. And then we're going to put them in these real life situations where people are hurting, they might be broken, there might need to be a level of care that's taken into these scenarios that is missed whenever there isn't adequate training. Now, I don't know this situation, and from just my simpleton experience is I think if you were to say what could have been different about this is how do we place in each of our police departments something similar to what we've done in Kansas City with our social worker program? How do we place within police departments beyond just a crisis intervention team? How do we place on every call, much similar to this, how do we place on every call an individual that's specifically trained to, one, be empathetic, also understanding that the law is really gray, it is not black and white, and 3 is that my position is that of servant first, enforcer second. And I think oftentimes the role of those in law enforcement, it places a greater respect to obedience and a submission than it does to I'm here to serve a situation to make sure that everybody's cared for and that everybody's safe. That's about all I can really say on a situation much similar to that without getting into a tangent.
I appreciate that as a post cursor to your statement, because it is easy to get on a tangent. I think that we as a society have equated mental health, the behaviors of those who are mentally ill with law breakers, instead of recognizing it as an illness and equating it with a need for healthcare. If you dialed 911 and were having a heart attack, they would send some police and they would send the fire squad. At least that's what they do in Johnson County. But the ambulance is coming first. It's a health issue, and the ambulance is coming. Fire and law enforcement are there to support. And I think that in our country, we're starting to make some shifts. Denver, I think, is one of the cities that have shifted to when it's a mental health call, they send the ambulance first and then law enforcement to support. And I think that's a really important to recognize that sometimes the situation escalates beyond mental health for reasons that we can't deny. And so you do need somebody there to help with getting somebody from a house or things like that. I could tell you story after story of folks that I've visited with who have had to dial 911 because their loved one was literally out of control. And I've informed them that when you dial 911, you're doing that because you know that you can no longer control that situation. You no longer have any influence, and you recognize that when you no longer have that influence, you no longer have control of the scene. The law enforcement will take control of the scene and will do what they think is best. So I remind folks to ask for a CIT officer, and I think all of the municipalities have CIT officers now, but not 24 hours a day. I do think that all of them have some mental health support, but not 24 hours a day. I think we have to demand that that become part of law enforcement's mentality, that we want mental health support. We don't want to be experts in this, and we want that mental health support with us as we go out on these calls. And not because we think that police officers are bad, though that's debatable. It's because they want to have the support they need to do what's best for the citizens in their community.
I want to piggyback on this also. I have to give Jackson County and Johnson County some credit, because I know that I work with the social worker in both Central Patrol, Liberty, North Patrol, as well as Johnson County. And they do, when they come to some minor issues that they can avoid jailing or punishing or handcuff somebody, they do try their best to kind of address that issues. Because they will call me for minor issues. They say, well, can you come deal with this instead? So we will go over it. So I give them credit, because instead of arresting them, they just call me and say, would you come address this, and then help them. So I do give them the credit, because over time they have gradually evolving to be a little bit more empathetic and more understanding of each individual person's need. So it might take time, but they have definitely a step in the right directions.
Definitely. Ash, in the chat box, somebody wanted to elaborate on what CIT was. So CIT stands for Crisis Intervention Training. Police officers are generally going to take the scene and do what needs to be done by force. And officers that have been trained in crisis intervention really focus on de-escalation more than escalation. So CIT is the type of officer, and a lot of those CIT officers interface with in Johnson County with Johnson County Mental Health. There's a whole group of them that are really work well together. But again, it's not 24 hours a day.
Whoops. 1 second. Sorry. Thank you for that, Kirsten. Somehow I lost my page. Okay, sorry. I'm going to skip the next question because I feel like you already answered it. So in October of last year, Reuters published a special report on jail deaths in the US from 2009 to 2019. This report showed that in Missouri, 42.4 deaths were related to mental illness or substance abuse issues, and in Kansas that number is even higher at 44.3%. How is the system failing people with mental illness, and what action can be taken to correct that?
I have thoughts.
I will just add this from my own personal experiences of being diagnosed with depression, PTSD from my time in the military, to my time incarcerated, to my ADHD and anxiety. It's like, what was the best alternative for me, who I was raised in poverty, grew up in poverty, lived in poverty most of my life. The stigma of mental health care was a problem for that, because our society is not as advanced in understanding, like, this is a need much physical as we addressed. So the alternative for me was drugs, because that was the easiest acquisition that I could make in terms of dealing with my own problems and my issues. Drugs and alcohol were that easy outlet. And so I turned to that outlet and began to use substances, which then creates another illness of SUD on top of my already growing problem. And then as the society around me stigmatizes my mental health care, to either say that I'm crazy or a whack job or whatever they're saying negatively about me, to make me internalize this. And then society saying like I'm not wealthy enough for mental health care, or I'm going through this system that doesn't take my mental health care seriously, so I'm on the back burner. All of these things added up to multiple suicide attempts, to multiple attempts to try to end my life as well as others' lives. Is this cycle that happens because of this lack of access. I think access both tangibly and access intangibly is I didn't have access because people like me didn't go to those places and we didn't seek that out. And access tangibly because I couldn't afford it, and where would I get it? I don't know. And so for as long as there's a lack of information, I think that more and more we're going to see those statistics kind of stay even, because we're not addressing the issues like we should, and we're not normalizing mental health care. We're not normalizing it. Unfortunately, people who come from where I come from end up we either change our lives, we go to prison for the rest of our lives, or we die. That's just point blank, and it's very, very few of us ever are able to change our lives.
I appreciate you sharing that very practical, real life experience, and it kind of bounces off of what I think is it's a solution, but it's not a magic. There's no magic wand. We all have to work at it, and that's to understand the impact of trauma. There was a study done in 1990, maybe 99, by Kaiser Permanente, where they accidentally discovered the impact of childhood trauma on adult health, and things like you discussed, poverty and broken families and mental illness in the household. All those things contributed to trauma in the adult. So traumatic events contribute to a trauma in the adult, and then the adult is going to try in the ways that they have the ability to do it to self-medicate, essentially. So I think the first and most important thing is, if we want to change things, I think we all have to become trauma informed. And there has been a big push in Kansas City to become trauma informed. But I don't think the average person understands how to do that, or even what that means. So I'm going to give you one quick resource, if you have your pens ready, on a learning website called Udemy, Udemy, udemy.com. There is a course. It's an 11-hour course called Certified Trauma Support Specialist. I take all of my staff through that. I follow this group that has put this out there from a clinician standpoint. And what it does is it describes trauma. It describes what happens to the body, and it describes how to help somebody who's having emotional, relational experiences due to trauma, which is most of the people that we work with. And so if we can begin to understand how trauma impacts the human brain and relationships, that will change the way that we as individuals deal with each other, and how we will insist on how our society starts to deal with people different. So that leads me to the second, maybe more practical thing. I believe every single municipality that has a court system should have a mental health court, because I do not believe that most people living with mental illness are breaking the law because they have criminal intent. Most of the time, and the experiences that I have had, and both personally with my children, and then over the course of the last 7 years of being with Pathway to Hope, those people are just trying to figure out how to get by. And frankly, they don't know the law. They're just trying to get by, and they end up in jail because they don't have access to mental health treatment. And the system treats them as if they are criminals when in fact they're just in survival mode. So I think and I think that Jackson County has a mental health court. I've heard that Johnson County is either getting one or it's coming. There's some talk about it. I don't know, because I don't really even understand what's going on in Johnson County from a court perspective right now, because we have a brand new building and nobody's in it. So anyway, but I think that we have to insist that we want mental health court for people who, especially if they have known diagnosis, and in order to be evaluated from a completely different mindset. So that's my 2 cents. And I have strong opinions about that.
Thank you, Kirsten and Jeff. And I do want to ask this kind of follow-up questions, but this follow-up question, what programs, and we kind of touched a little bit on this a few minutes ago, what programs exist within the prison system to address the needs of individuals with mental illness? And we already touched on the second half of that question, which was what happens to those people after they are released from prison. But so what programs exist within the prison system to address the needs of individuals with mental illness?
Yeah, you have psychologists that are on staff, both in the state level and the federal level. I think, you know, I don't want to continue to harp on problems, but I will say here's the issues. Like, there's really good care inside of there. They're going to be seen. They're going to have a counselor that they meet with. They're going to talk to them regularly. They're going to be on medications that they need. They're going to be cared for. However, there's a unique dynamic in a prison system versus, let's say, on a term that we use on the outside, on the free world, that dynamic between therapist and patient is inside of the facility. The psychologists and the counselors that are on staff are trained much similar to corrections officers. So the psychologists and psychiatrists that are on staff with the Federal Bureau of Prisons and State Department of Corrections, they are trained, taught, ingrained, and cultured into the correctional officer system. So for example, the counselors at the Leavenworth Penitentiary, a psychiatrist would come out of their school or come into the job for the first time. They would be hired. They would be trained as a corrections officer first. Then they would be ingrained into the culture of the corrections officer system. And then they would now have the job as a psychologist for the Federal Bureau of Prisons, expected to respond and behave the same way as a corrections officer would. Now, it's a little bit tricky in how you want to define that relationship between a counselor and their patient. I know that there's some ethics that you got to follow, but one thing that I've experienced in my time is that we often objectify those others, and in the correctional system there is an objectification in order to create a boundary between staff and those incarcerated. And for lack of a better term, and just in this, I don't like using the term, but prisoners or inmates are the other, and all of the staff are in the culture. And so when you have this view that they're the other, there's a certain level of failing in the care that you need for that person. And we see it so often is there is a desire just to simply diagnose, give what's needed to kind of level people off, and then send them on out the door without that continuum of care going into them returning into society. I know that in places, and here's a major problem that we have. If you'll notice, most of really the vast majority of prisons are located in rural environments. So for example, we did have a prison here in Kansas City. Actually, they just shut it down the last couple of weeks. There's no inmates in it. We used to have a downtown prison for the Missouri Department of Corrections. We no longer have that. They're shutting that down. But the prisons that we do have are in places like St. Joe, Cameron, Missouri, Chillicothe, Missouri, Boonville, Maryville.
Fulton.
Yeah, go ahead, Ash.
I was going to say Fulton, Missouri. Also,
there's Fulton. Yeah, Fulton.
I happen to be from there, so
yeah, there's Fulton has a big prison. That's a rural environment, right? Where do most of our people that are incarcerated come from? They come from urban environments. And where do what demographic is most incarcerated in this country? It's African Americans. And what are most demographics in those rural environments that are on staff are white rural Americans. And so you have this relationship dynamic that doesn't fully care and give the level of care that they need. Now, that's not speaking to the many programs and volunteers and those that serve inside of the prison environment that do a really great job, which there are volunteers and there are community resources that are going into these places. For example, in Lansing, which is the closest prison that we have to Kansas City, is in Lansing. They're really leaning on volunteer based. How do we get community organizations inside of this institution? How do we really change that dynamic? And I think prisons are kind of following suit, as seeing that we need to take the care and the help and assistance away from the local or the state level and give it back to those that do the work within the environments to which the offender is going to return to their community.
Great. I think we may have somehow lost Kirsten. Hopefully she'll be able to get back in. Oops.
Hey, she made it back. There she is.
Yay.
About this time last night, my Wi-Fi was having really bad downloading speeds, and I'm like going, I don't know what's going on with Google Fiber, but it kicked me off. I'm back.
Usually my Wi-Fi issues are related to some dog bouncing my keyboard.
I did yell at my husband. I'm like, you're not streaming. Get off the internet. Stop streaming.
Yeah, my golden retriever likes to make an appearance during Zoom calls, so she's in her kennel at the moment, because otherwise she also tends to kick me off too. So, so I like to blame my Google Fiber issues on the dog. So, so this is kind of obviously a bigger question about the current climate. So how has the ongoing COVID-19 crisis affected and or complicated the lives of people living with mental illness? And has there been a rise in mental health diagnoses as a result of the pandemic? And in particular, how has it affected women and children? I do know from working with Pathway to Hope that we have had some folks come back and say that, you know, the worst thing you can do to people living with mental illness is isolate them. And obviously that's essentially what this pandemic has done to all of us, right? We no longer go anywhere. We no longer do anything. So I want you guys to kind of speak on that for a minute. Kirsten, do you want to go first?
I'll let Car, because I can wrap up anybody.
Yeah.
I can talk for an hour on this. Go ahead, Car.
Well, no, I was just going to think about like how would it affect them. That's why we did the COVID-19. That's why we did the shelter in place program for that. But our program, I want to kind of emphasize, is a little bit different from most programs. We are really a body, mind, community program. What I mean by that is we encourage everybody we work with to take care of themselves, whether we take them to exercise, whether we try to have kind of building that exercise is really important because of it's a discipline, it's a form of discipline. If you take care of your body, you take care of yourself, but it takes discipline to get there. And same as your mind, that's why we provide counseling, we provide all these things. And so that again, you help them discipline, because if you don't rein in your random thoughts or your running thoughts, and you're not going to go anywhere. And so when we created the program, we try to really emphasize that we want to address those issues before we kind of really find out what our needs are. And then the community is really important. That's why we are kind of in a group home sense. Even when we move them out the apartment, we bring them back. So it's really important to have the communities, the sense of community, because none of us can live alone in a sense, in the long run. COVID forces us to do that. But at the same time, we try our best to bring them back into some form of community. So that way they're not just by themselves, feel like they were struggling on their own. And I think that's really important for any program to really look at the body, mind, and community, as well as also making sure that they have the support along the way, because otherwise, I think humans are born to be in a group. I don't think most of us don't want to be by ourselves. And then I have one gentleman I work with like recently, because of COVID, because of all this, because he has Asperger. And so, but he will not admit to it that he has it. So it took us 2 months again to help him settle down, bring him into a community to really address that. But in this sense, the COVID kind of forces him, he lost everything. But because of that, he lost everything, he's willing to work with us so that we can take our time. It forces him to slow down so we can have a doctor and a psychologist to look at him to find out, hey, I think this is part of your challenge over time. So in a sense, it could be really negative, but in a sense, it could be positive. That depends how we address it, how we make it work. So in his case, the COVID actually helps him. But also, I think as a community, we need to address the individual, not one size fits all. So we have to look at each one of, and especially when it comes to mental health, it's all individuals, because nobody is the same. We don't have the same depressions. We don't have the same bipolar. We are all different. We have our own challenge. So that's how I see it.
I would say, trying to give my own personal experiences. We at Connections, we're running roughly about 40 individuals per month through our in-person community-based training and enrollment. Well, when COVID hit, we dropped all the way to only serving about 9, maybe a month if we were lucky. And that was due to a vast array of issues. But one such problem was, internet connectivity. And when the world kind of shut its doors, those that we used to be able to serve by either going and picking them up and bringing them to us, or them riding the bus to us, we were now losing. They were falling in the gaps, and unfortunately, we were trying to bring them into being able to have the resources and tools they need. Thankfully, from the Kansas City Health Foundation and others, we were able to gather up a bunch of Wi-Fi hotspots and a bunch of tablets, and we spent hours and hours walking people through and trying to get connected. But I think from the mental health aspect, I'd speak from those that are incarcerated. I was speaking to 9 individuals that were just released from the Federal Bureau of Prisons, and oh my, I don't think there's ever a great time to be incarcerated, but I definitely think that in COVID times, it's definitely not a good time to be incarcerated. The amount of lockdowns that they've been on, they haven't seen family in a year. Their visits were taken away from them, connections to the outside world. Carr hit the nail on the head. We're a community-based people. We need people around us, and we need community around us, and that exacerbates some of those issues and problems that we see. And from my personal experiences, I have 3 kids. I have a 6-year-old, a 3-year-old, and an 18-month-old. And my 6-year-old has been with me this whole time, and I'm trying to do my job as a program director and get him. He goes to the Academy Lafayette, and I'm trying to get him on his classes every day while dragging this 6-year-old to all my meetings. And he's a pretty high energy kid. And so I have that. And then my other 2, my 3-year-old and my 18-month-old, their daycare closes down. And I'll tell you, I've suffered so much depression and anxiety and anger issues, and trying to figure out, how do I even do life? How do I figure this out? Because my wife gets up at 6 and leaves the house, and then doesn't get home till 6 in the night. So all of these responsibilities kind of fell on me, and I found throughout this experience is my mental health issues were exacerbated from COVID, and it took some really, thankfully I've been able to manage my health. It took some serious reaching out to people, reaching out to my doctor, being willing to go and sit with a counselor, and I think if I'm experiencing that and struggling with it, I can only imagine those that are in the homeless community, those are in the lower socioeconomic status, how they're trying to deal with it.
Well, I'm going to piggyback on that a little bit. What Jeff just said is the economical challenge. The population we serve doesn't have the means to get Wi-Fi. They don't have a computer. They cannot connect. We say, okay, why don't you go to Zoom? We can't just go to Zoom. What do we use to Zoom? And so again, that kind of brings up like economical challenges that they have to face. We might take it for granted, but in reality, they can't get on. So even they might have the heart to do that. So I just want kind of like point that out. Yeah.
Yeah, I would agree with all of that. From the end of March until the end of the year, I did 55 suicide assessments, and that's not an exaggeration. Like literally, these are people who are on the verge of having a plan to kill themselves. And in the 6 years preceding COVID, I probably didn't do 15 altogether. So when we say that this has been a stress, it has been a complete and total stress. I always like to report that as far as I know, all of those people lived. They got connected with the correct resources. And some of that was just making sure that they understood that social distancing is really about physical distancing. You don't have to stay away completely from everybody that you love. I mean, people were isolating themselves in their house and feeling like they couldn't even talk to their neighbors, so helping correct some of that misinformation that gets blown out of proportion because we have interesting ways of communicating that information. But I think of the one gal in August when they were starting to talk about kids going back to school. And she has pretty serious depression already. She's on disability, and she had 2 children that she has shared custody with her husband. So they're divorced, and she's their primary caregiver. And as they were talking about sending kids back to school, and there was all kinds of choices that had to be made, she was really distressed to the point of feeling like it would have been better for her to be dead than for her to make the decision about what was the right thing to do with her kids. It was so stressful for her that she would make the wrong choice, and that choice would somehow harm her kids. And I would venture to guess that all across this city are hundreds and maybe even thousands of people that are very similar to who she is. I can't imagine that she was an isolated case, and maybe not to the same severity. But I know my own daughter had to return to work after having a baby, and she was stressed out about, ways what kind of daycare am I going to find, and how do I make sure that they're safe? And there's just a higher level of awareness to the potential threats in the world. And if you think about what mental illness is and does, those types of life stresses really stress the brain and cause an individual to feel completely overwhelmed and without resources to respond to that stress. And Ash, you may be able to say the statistic. I can't remember. I was reading an article about it was like 425 million women have left the workforce. Some crazy number like that. I can't even imagine what that means to people's lifestyles and to their stress levels as they lose an income. That's a pretty stressful thing for people in America who often live paycheck to paycheck. And if we're talking about how expensive mental health care is, that's probably going to be one of the last things that they're going to invest in when it comes to taking care of themselves. So I think that COVID has heightened our awareness to a lot of things. I sat on Monday, we've we are blessed to be the recipient of the Church of the Resurrection's a grant that they give out each year during Easter. And we are one of 2 mental health organizations that are going to receive that. So I sat and chatted with their staff on Monday, and I said, I feel like the silver lining of this is that we all now understand what isolation does to the human. And that is a silver lining. I hope that we don't lose this understanding that we can't live without relationship, and we desperately, desperately need them. But we also, in our own struggles, because I love, Jeff, that you admitted to your struggle in December. I took 10 days off, and probably I should have taken 20 because I was just so done with everyone and everything. I'm still under clinical supervision. And so after the first year, I went to visit with my supervisor, and I was supposed to see clients on that following Friday. And he said, are you ready to see clients? And I said, you know what? I don't give a damn about anybody's problems right now. I probably shouldn't see clients. I had to really suck it up hard to get back into the groove and feel like I was ready to be a good clinical provider. But it did take it out of all of us. And I think it is important to think about how am I taking care of myself? How have I changed my self-care routines? What was I using to cope prior to COVID? What were the shortfalls in my own self-care? Do I even think about taking care of myself? My self-care routine starts every single morning, often after I get out of bed, but I try to do it as close to waking up as possible, just asking myself, how do I feel? And to be able to identify my own feelings about what's happening in the world without any input from anybody or anything else. And then the second question I ask is, what do I need? To identify and have that connection with myself, because I know my day is going to be filled with so many other people's needs that if I don't address that with myself first and do what I can to understand my own feelings and meet my own needs, I'm going to be in no position to take care of everybody else. So put the oxygen mask on yourself first, and be really particular. I make appointments with myself to breathe. That seems a little silly, but I do. During the day, a couple of times a day, my timer will go off, and it's a reminder to breathe, and I'll sit and do some deep belly breathing, which I'm a vagus nerve evangelist. So someday maybe we can talk about what the vagus nerve does and why breathing is helpful. But most of us hold our breath, and holding our breath tells our brain that we're in some sort of distress. It puts us into fight or flight mode. And so if we can learn to take some deep belly breaths and burn some neural pathways around good relaxed body, it takes me 1 or 2 or 3 breaths after I've been triggered to just come back and say, okay, my prefrontal cortex is back online. I can think and I can problem solve and I can help you. And I feel like that is another thing from a silver lining approach with COVID. We've talked about these things. We're more interested in these things. And I think we're in a better position to help each other if we're really using the time wisely and learning how to take care of ourselves. Like I said, I could preach for a while, so.
Obviously mental health is isolating. Then you add in COVID, it isolates you even further. So it's obviously it's a bigger problem. And I thank you all for addressing that. Now the last question that I have before I turn it over to everyone else. Why is there such a stigma surrounding mental illness? And what are some of the things that we can do to help destigmatize mental illness, both individually and as an organization?
I think the why is a complicated question. I think over the course of time, we've been beings that like to categorize and label and judge. And I think mental illness on some level has represented somehow we're less than, rather than it's just a medical issue. It's a behavior that scares, or sometimes mental illness behaviors scare other people and put people on defense. And we say things like crazy, and there's a pitting against the way we've treated mental illness, and both in our Hollywood, the way Hollywood treats it, and then the way that we've institutionalized people and taken them out of their communities. And then when we decided to stop institutionalizing them, putting them back in their communities, instead of putting enough funds into the systems to help them, we ended up putting them in jail, which just continues to make it worse. I think the way, if I could encourage what you guys are doing now, I think that it is really important that we talk about things from a Me Too standpoint. So when you, Ash, who look pretty put together, let me tell you, I wouldn't have guessed that you have any struggles. But when you say, I have a mental illness and here's what it is, and you normalize the human experience, because I think it is a human experience, I think that begins to take some of the air and the pressure out of stigma. When we sit here and talk about the ways in which we can treat people differently, that takes some of the air out of those sails. When we insist that people be treated dignified and they be given housing and opportunities based on what they have to offer, I think that takes some of the stigma out. So it's really recognizing that Jeff talked about it in the prison system, the us and them thing. I think when we stop talking about mental illness around an us and them perspective, and it's just all of us, we'll stop tolerating anything that really is stigma, because when you talk about them, you're talking about me too.
Jeff, do you have anything to add there?
Yeah, I mean, I can't add anything else than what already been added, but I will say in our own personal lives, I think if there's anything that we can do is take yourself seriously. I think it starts with us and understanding who we are. And don't believe the negative messages that you've been told your whole life, whether I think I saw it in the chat boxes. People think others are just acting out for attention. Is even in your own life, don't believe the negative message that you're just acting crazy or you are acting out. Recognize like there's a brain in there that's, like Kirsten said, it's an organ and it needs to be cared for. And sometimes, and I'm not saying that we all need to run off and get diagnosed, but what I'm saying is like, for example, my wife and I, we go through counseling, right? We go to marriage counseling. Well, why do we go to marriage counseling? It's not because our marriage is bad. My marriage is great. I love my wife and we have a thriving, healthy marriage, but we go because we want to care for our marriage. We want to care for ourselves, and that relationship that we have is oftentimes when we're facing difficulties, we have this mentality of suck it up, or just get through it, or you're being a baby, just get on with your life. Whereas instead, if we had a response of, my brain is this organ that works, that's alive within inside of myself, that's needs cared for and needs to have an understanding about it that maybe is beyond me. I might need to go to a counselor. When we normalize it for ourselves and we begin to see it for ourselves and take care of ourselves, that can't help but bleed out into the world. And then when we look at individuals that maybe are acting out or who may have a diagnosis, let's not treat them as the other, but let's just view them through the lenses. They might be different, but they're still human beings too. And probably let's change our vocabulary around it as well. If you see people joking about it, maybe hold people accountable. Be like, that's not cool. Don't laugh. Don't joke about it. And that's maybe the power that we have right now in the immediate. And then ultimately, vote. We're America. Vote. Go research your candidates, understand their policies, and vote. Please vote. It's America. That still means something. It still creates great change. I mean, I'm seeing it just in America right now, the last few months, what it means when we vote and we put leaders in office. when we affect that change that way, we can affect a lot. And if we're apprised to who we're voting for, not just based on whether they have an R&D in their name, but rather that they're concerned about the issues, they have a track record for caring for the community and making real positive change, vote for that.
And I kind of did want to add on to a little bit of what Kirsten said, because she did address me personally on this one. I have actually always been fairly honest about my struggles with mental health. I grew up in an abusive home. In fact, my mother was the abuser. My dad worked a lot. He was a physician in a small town, and the only surgeon in that town. So there were times actually during the week, I barely saw him at all. And then he was only there really on the weekends. I mean, but especially as a younger child, he did not come, or he left for work before we ever got up in the morning. And then he didn't come home until after we were in bed. Now, obviously, once I got to high school, started staying up later, these things changed. During that time, I also protected my brother from what was happening to me. And it is, some of it is that whole Asian family like drive to succeed. So the slightest screw up and, it's a big issue. And I did have multiple suicide attempts before the age of 18. And my mother, especially because she attached such a stigma to mental health and receiving help for that mental health issue, she refused to get me counseling. After that, actually my fiance, the one who passed away 20 years ago, actually stepped in, and he was the one who got me help. He found me a therapist. He paid for it because I was still under my parents' roof. He was a year and a day older than me. So he was already out of high school. He was earning money. So he was able to take care of that for me. And then I made him certain promises, and I said that I would never attempt it again. And I did not. And I have not, even after he lost his life to suicide. It was challenging. But I went to therapy. I did the work. And I will say that because I have been honest about my story, and I have been in emotionally abusive abusive relationships since. If you're a League member, you can access that. I did write a story for Inside Scoop a couple of years ago, when I was the editor of the magazine, that details that story, with emotionally abusive, in an emotionally abusive relationship. And a lot of that was because this was the behavior that was modeled for me as a child. And that was my perception of what love was. And so I allowed it to continue for a year, until I finally just had it and ended the relationship. But realized there was extra harassment still coming from him for years afterward, or for at least a year after the fact, after I kicked him out of my house, after I took back my life. But I had resources to get out of that relationship at that time. So in telling those stories, I have had people reach out to me when they have needed help, because I'm a safe space, right? Because I'm not going to judge them for what they tell me. And I'm going to do my best to help them and provide them with resources and whatever else they need in order to get that done, and to take their life back. With that being said, I want to open it up to everyone else. So if you have any questions, this is your time to go ahead and ask and have those answered.
While everybody's thinking about questions, there was a chat a few minutes ago about the quote, "You don't have the right to feel sad or depressed because others have it worse." And I think that is that's part of the stigma, right? Is that mine isn't as bad as theirs, but I think we have to honor our own experiences. my brain is different than your brain, and I can handle, oh, good grief, I eat stress for breakfast. But other people don't have the capacity that I have. And so I think to honor yourself and your own experience, even when others aren't doing it, takes courage. And so to say, I am sad, and to stay with your sadness until it passes. And truthfully, sadness and fear and some of those things, when we resist them, they come on even stronger. So to sit with my sadness and to say, I am sad, and to be real about that with yourself. You may not be able to be real with just everybody. Brene Brown is a great author and speaker, and you guys may be familiar with her. And she says, you have to find safe people to be real and authentic with. You can't be authentic with everybody, because not everybody's going to understand. And I've come to the place in my life where I don't care if everybody understands, but there's a part of our life where we do care, and we need the approval of others. And so it's okay to keep yourself protected, but not abandon your own feelings and your own suffering, even if somebody else has it apparently worse than you. Your experience is your own, and you have to own it.
And it's not a contest, right?
No.
Every person's issues are different. Any questions?
First of all, I just want to say thank you to everyone for being here. This has been really insightful. I feel like I've learned a lot, and just thank you for that. A lot of what we're talking about obviously has to do with the person who's struggling with mental illness and the services that are provided to them. As somebody with a sibling with an undiagnosed mental illness and a family that could support him if he wanted to get help, that's a very isolating and stigmatizing situation as well. So I was just wondering if there was something to be, I think, I don't know what exactly I'm trying to say, but essentially it seems like a lot of the organizations step in as basically like families for these people whose families have been ostracized. Some have been separated from their families. What support is there, or do you know support for families that want to care for their loved one who is not easy to care for?
Yeah, that's actually part of what Pathway to Hope does. In fact, I could tell you story after story. I have, I think I now have, my husband and I have 7 children between us, and 4 of those 7 children have some degree of mental illness. 3 of them are pretty serious mental illness. So I very much understand both both sides of that equation. I speak to parents all the time who have adult children who either they're diagnosed, and Cara alluded to it, they're not willing to admit that they are living with a mental illness. And so the family's struggling because in our society, you don't have to take any medication you don't want to take, and mental health medications is one of them. So we spend, it's not just me, I spend a lot of one-on-one time with folks, walking through healthy boundaries and good self-care and how to stay connected to your loved one, because abandoning them because they won't get treatment or help is not helpful to them at all. But I call that the messy middle, where they're not willing, but they still need the love. And I describe a situation with my oldest, my birth child. She had already walked most of her life with her younger sister who struggled with mental illness from 12 years old. And so she had seen my will to make sure that you have good mental health treatment. But she was over the age of 18, and I couldn't make her do anything. So at one point, while she was self-medicating, living from couch to couch, I called her and told her she needed to come get her stuff from our house. And if she didn't, I was going to put it on the street because the trash would pick it up on Monday. And if she wanted to pick it up from there, that was fine. But I wasn't going to tolerate the disrespect that she was giving to me at that period in her life. And then I had to breathe in a bag after I did that, because I knew the consequences of a boundary like that. And so I told my husband that I needed to be prepared to identify her body. I knew that boundary made her be homeless and that could drive her to a place of overdose or any other number of things. I'm not unfamiliar with what the city can do to a homeless girl, but I needed the boundary for my own mental health, really. And so we talked through what that reality would look like, having to go and identify her body. The good news is that we didn't have to do that. She eventually found her own rock bottom, and we were able to help her get treatment. It has been a rocky road. She came home and told us that she was pregnant, and that was kind of her turnaround. So her little girl turns 3 in a few weeks, and she's just now really on her own actively pursuing psychiatric care and counseling, and she's in a rural community that doesn't have a lot of those resources, so she's having to work really hard for it. But she now values that, and she will say that it was because I wasn't willing to take responsibility for her mental health. She had to do that, but I never told her I didn't love her, and I never told her I wouldn't support her. I just told her she couldn't live here if she wasn't going to take responsibility for her mental health. So it's that maintaining that loving position while making sure that you're not enabling something that is unhealthy for them. And that is a very fine line to walk. And I know it because I've walked it with some of our other kids, not quite that dramatic, but it's a fine line to walk, to express love and to say, I love you and I love me too. And you don't get to treat me this way. You can't treat me like you're treating yourself. I'm not going to tolerate that. I want you to treat yourself better. And when you're ready to do that, I'm here to help. And we did stay in communication.
What's really interesting, and this may seem like a very easy jump for a lot of people, we had when I was a junior in high school, we had an intervention for my mom for alcohol abuse. And a lot of what you're talking about are boundaries that are around substance abuse things. But I feel like, at least for me, it's not something that I also look at as mental health. Like, for some reason, I have separated substance abuse disorders and mental health, but it sounds like a lot of that is very similar. And I know that we have like Al-Anon and things like that to support families of people with substance abuse disorders, but it's enlightening just for you to say that it sounds like it's very similar. And obviously, just we've talked about, substance abuse disorder is a mental illness, so it does make sense that
we as a society, we siloed substance use and mental illness separately, but it's always been a mental illness. Both Pathway to Hope has support groups for families every Thursday night in Olathe at College Church of the Nazarene. There's an organization called NAMI, National Alliance for Mental Illness, and they have a number of chapters across the city. So you can go to NAMI.org and you can find a chapter that's local. And they also have support groups and education. And you can find that anywhere. When somebody calls me from another state, looking for resources like Pathway to Hope, I'm like, find a NAMI, because they'll do the same thing. They have family to family groups, they have peer groups, they have education. It's the same type of support as you would find for Al-Anon.
And to add on a little bit, you are like very early in the conversation, kind of actually towards the very beginning, when you were talking about Pathway to Hope, you did mention the E3 program, and the E3 program at Pathway to Hope, I do happen to be a facilitator for that as well. But that program actually educates you on how to deal with mental illness in the family. And then so that you know what those how you can de-escalate, how you take care of yourself. I'm obviously skipping over a lot of things, but it's a fairly in-depth course.
We're working right now on putting that online so that individuals can actually go through it in a more self-paced standpoint, and then join into like a discussion group each week. So hopefully before the fall, we'll have that done. Being a small organization with a lot of really great volunteers, things move forward within their timeframes, but we're really excited because we're rewriting the curriculum as we're getting it ready to go online. So it's an exciting time to reach out and help people.
Thank you.
Yeah, Lexi, I just wanted to say this, like, when we help families and we're supporting families in the transition from incarceration of their loved one back into the community, one thing we always say is, you're not the doctor or the brain surgeon, right? You wouldn't go into the operating room and say, like, hand me a scalpel and start operating on in a patient, right? It's like, why do we like do these maneuvers and tools with our family members to say, like, if I did this or if I did that and I do this, and then they'll get better. Really the focus should be on it, like, how do you care for yourself in dealing with that person? So I have a brother who's just, I can't speak candidly. I'm a pastor and I love Jesus, but I want to punch the guy in the face, like, repeatedly, because of the things that he does. Like, dude, come on, dude. But I can't change his life, or I can't operate on him. One, because I'm not a counselor. Two, I'm not a therapist. And three, like, it's so close to me, like it boils my blood. I need to care for myself first and understand, like, if I see a counselor or a therapist about this, I'm going to be able to deal with him more than rather than try to change him or change the situation. I'm just going to be able to change my perspective. And so really caring for me. And that's how I address that situation in if you're dealing with, like a relative or a loved one, like, you just want to get your stuff together already.
It is also my brother, and I also have moments of violent thoughts too. And I also love Jesus. I appreciate that.
Keep it real. Keep it real. Yeah, keep it real.
Right. It's a human condition.
Are there any other questions? I think we have time for maybe one more, if there is one.
If no one's going to ask it, how else can we get involved with your organizations or learn more about your organizations? And I don't know if this was in Carr's bio, but he also has a TED Talk.
He does.
Yeah, Carr is awesome. I love Carr. Pathway to Hope is in a growth mode. I'm keeping my fingers crossed that in the next few weeks we're going to be able to make a major announcement for a lot of ways that you could get involved with Pathway to Hope. Right now, I'm breathing a bag for my own daily stress, because it just managing the potential growth is kind of a big deal. But I really feel like honoring yourself, understanding what you need and what your community needs, being a champion for change, it makes such a difference. And then there is on our website, and thanks Jeff for sharing that there in the chat. I'll try to remember to do that too. There's a volunteer application, and it kind of helps you see what the kinds of things that we need. Currently our volunteers lead groups on Thursday night. Ash referenced the E3 course. Beyond that, events, but we haven't had very many events because of COVID. So it's hard to get involved.
And we still have some positions to fill on our development committee too.
Yes.
So you can always reach out to me as well, involving Pathway to Hope. But yeah, if you want to volunteer within the organization in a more direct manner, then yeah, Kirsten's your go-to. Or you can go to the website, which she just posted. All right. With that, I am going to close this out. I want to thank you, Kirsten, Jeff, Carr, for being here tonight and spending time with us and talking to us about this difficult community issue. And thanks to the rest of you for spending your evening with us too. I know you have other things that you could be doing, so I appreciate you being here. Thank you so much, ladies, and Jeff and Carr.
Yeah, thanks so much. Thank you, everyone. Thank you for the honor.
Ladies around here. That's
it's great. Thank you for what you do. Thank you for your work. Keep up the great job.
Yep.
Thanks,
everybody.
Bye.
Good night.
Thank you.